Actually, I'm going to give two talks today on very similar topics. So I actually prepared a long presentation which has been divided in two parts, and I hope this will be more fruitful for the discussion. So first of all, I think we need to take this laterally. So whenever we use antiplatelet agents, we need to think whether there is one which is more effective or more potent than the other. And we really can't tell on top of anticoagulation if there is a difference between aspirin and clopidogrel, but we do have data suggesting that from the CAPRIE trial, actually clopidogrel might be slightly more effective than aspirin without any substantial increase in bleeding. Of course, in patients not on anticoagulation. So this is the first piece of the puzzle. Then we have to understand that the patients with coronary artery disease, especially patients with unstable coronary artery disease, are at risk of thrombotic events. And even if we treat them with dual antiplatelet agents, we cannot really stop all the atherothrombotic processes which are going on in those patients. Thus, we can think that we could go on farther along the way of stopping thrombosis, of inhibiting thrombosis. And so we have data from the TIMI-51 trial, ATLAS-ACS, suggesting that if you add rivaroxaban at a low dose to aspirin or aspirin and clopidogrel in patients without an indication to anticoagulation, you actually substantially improve thrombotic events, albeit increasing bleeding. So we know that if we push further, we are going to decrease thrombosis. The point is, when is this thrombotic benefit being offset substantially by a bleeding risk? And these are the specific data. We can go back on this. The key point is that you see there is a strong trend towards a reduction in mortality if you add rivaroxaban in these patients. So you actually save possibly lives, but you do increase highly significantly bleeding. So why don't we give rivaroxaban to all our stable patients? Because we need to make individualized decision making probably. And indeed, the effects are quite consistent in most patient subsets. It's also true that some similar data, albeit not as convincingly, have been produced regarding other novel anticoagulant agents. So the question is also whether this potential benefit with rivaroxaban is unique to this drug, or we have also similar effects with other drugs. This is a small trial on dabigatran. It's not very conclusive. And the large trial on apixaban was actually negative, without any thrombotic benefit, but increased bleeding risk. The caveat was probably that the dose was not the best one which could be chosen, but we now see that there is some heterogeneity in the way these novel anticoagulants can work when added to dual antiplatelet therapy in patients with unstable coronary artery disease. And these are the specific data. As you can see, no benefit on thrombotic events, no benefit on death, but significant increase in the risk of bleeding. And then we face, unfortunately, the only randomized trial which can inform a bit weakly on the questions we are posed today by these very interesting cases. So this is the WOEST trial. It's a very nice trial from the Netherlands, very smart example of how research should be conducted today. So the idea was to randomize patients with an indication toward anticoagulation, so not only atrial fibrillation, but also VTE, pulmonary embolism, to triple therapy or clopidogrel plus warfarin without aspirin. Of course, the limitation is that the sample size is not very large, not only atrial fibrillation and warfarin, which in the current scenario is probably not the first choice for our patients because of compliance and possibly also because of some additional benefits that the novel anticoagulants can provide. As you can see in the WOEST trial, you had a significant benefit in terms of double therapies with lower rates of bleeding, and more importantly, you had significant benefits on thrombotic events as well, which is kind of awkward and surprising, but might have something to do with the fact that excessive thrombosis prevention might lead to, on the other hand, a bleeding risk, and this bleeding risk sometimes is one of the factors to bring out additional thrombotic events. The key point is the data, if you trust them, suggest that you might actually reduce death in your patients if you stick to double therapy rather than triple therapy. Of course, statistically speaking, this trial is very small. This looks like more the effect of play of chance, but these are the data and we need to factor them and take them into consideration. The key point, conversely, is that you don't see any risk in terms of the stent. So you don't see a risk of stent thrombosis, and remember that these stents were not only best generation, new generation drug-eluting stents, but also stents which nowadays we would not consider for routine practice. What is more important, in my opinion, in the cases we have seen is a very recent trial which was published a few weeks ago on the New England Journal of Medicine, which is the Leaders-Free trial. So this is a very important trial because it's one of the trials which have prospectively demonstrated that the concept that a very effective drug-eluting stent is also less safe is wrong. And actually they've shown that a very effective and very well biocompatible drug-eluting stent is safer than a bare metal stent, not only obviously more effective. So in this case, patients who were at high risk of bleeding were randomized to biolimosoluting stent without polymer or bare metal stent, and the endpoint was an endpoint of cardiac death, myocardial infarction, stent thrombosis. And note that all patients received only 1 month of dual antiplatelet therapy, and this is very pertinent for any of the cases we have seen. And the results were very, very striking. Actually, we can think that they were in line with the amount of data accrued so far by meta-analysis, but the key point is that you have very good results in terms of the primary endpoint of cardiac death, myocardial infarction, stent thrombosis, which was significantly reduced by biolimosoluting stents, and also very reassuring results in terms of stent thrombosis with a low risk of stent thrombosis despite the high bleeding risk, which typically poses the patient at risk also of thrombosis, and also an interesting reduction in the risk of myocardial. If you believe this trial, you actually put the patient at risk of more myocardial infarctions. So you're not doing, or you will not be doing any longer a good thing. So we can now move to the guidelines, which we will cover also in the next presentation. We have the guidelines on atrial fibrillation. They are very interesting. Unfortunately, they are not that well updated. So the last version is from 2012. We look forward to new guidelines. These guidelines suggest a complex decision-making process to decide whether or not to use an anticoagulant, and especially whether or not to use a novel anticoagulant, and which one if you decide to use a novel anticoagulant. My personal recommendation would be to change the way we think and consider novel anticoagulants as the first line therapy in atrial fibrillation, and consider warfarin only in those scenarios in which they are not indicated. The key point, as you can see, is that antithrombotic therapy is recommended in all patients, especially patients with high CHA-VASc score, and in patients with low CHA-VASc score, you can avoid oral anticoagulation. and these are pretty straightforward. Note that the guidelines don't really push the case for novel anticoagulants, but leave the decision to the physician. I think this is less pertinent here, is more pertinent in some settings in Europe where costs may play a role in decision making and in choosing the most appropriate oral anticoagulant. Additional data, whenever you cannot use warfarin or similar drug, you do need to use a novel anticoagulant such as dabigatran, garoxaban, apixaban, and in the future most possibly other drugs such as doxaban.
He actually has 20 minutes. They gave only 10.
You need also to factor in bleeding risk, and this makes kind of a difficult scenario in which you have some risk suggesting you need to use a drug and some risk score suggesting you shouldn't use the drug, and this is the S-blood score, but there are also other scores which is important to take into account. Not necessarily every score is effective. There is some suggestions that the ATRIA score is better than the CHA-2DS2-VASc score. From your perspective, I would really be interested in having national confirmation that these scores are pertinent and accurate in the case of Saudi Arabian patients and so forth. And we also should not forget that now we have interventional means to decrease the risk of the patient with atrial fibrillation. There are data suggesting that if you close the left atrial appendage, you actually have similar or even better results than anticoagulation in suitable patients. So we should also consider that the Watchman device or similar devices from St. Jude might actually help in decision making, and whenever we have a high bleeding risk PCI, we may consider closing the left lateral appendage and then consider the patient more or less fixed in terms of the risk of atrial fibrillation thrombosis. The stable care guidelines are a little bit more recent, from 2013, and here we have, of course, clear-cut indications for the choice of devices, and antiplatelet therapy, of course, as we know, is recommended explicitly. And we have also guidelines on myocardial revascularization. This of evidence for the class of oral anticoagulants is inconclusive and requires further study. So, of course, no clear guidance from the guidelines, if you will. And again, the de facto statement that long-term exposure to tribal therapy is associated with a risk of bleeding, and unfortunately, evidence is too weak to provide clear guidance. Tribal therapy is probably best reserved to only patients who are a low bleeding risk and have a very compelling indication, and so forth. Tribal therapy also must be considered as a very short-term indication, short-term regimen to minimize risk of bleeding, because again, we must remember that the bleeding risk is stochastic in a sense. So every day you keep the patient on tribal therapy is a day in which the patient is at risk of bleeding. The fewer the days, probably the lower the cumulative risk. And also remember to add as many approaches and regimens which can decrease the risk of bleeding, for instance, by protecting the GI system with the PPIs, and these are the explicit guidelines. The concept that you need oral anticoagulation if the CHA-2DS score is above 2. And that you can also consider, in keeping with the WOEST trial, dual therapy with oral anticoagulants, possibly novel oral anticoagulants, and clopidogrel only in selected patients. Thank you.
Thank you.